My name is Akhnuwkh Jones, and I'm from Philadelphia, Pennsylvania, which is in the United States. That's where I was born and raised, and also I did my schooling, medical school, in the neighborhood not too far from where I grew up. I did my training in internal medicine at a hospital called Lankenau Hospital, which is in the Philadelphia area. And then after I completed my training, I did hospitalist work in Pennsylvania also for about 5 years. And I was the primary hospitalist for the primary care team that was in the surrounding area. So for example, it was a group of physicians that if one of their patients would be admitted to the hospital, instead of them managing patients in the hospital, I would be the primary physician as an inpatient. So after my time spending there, my family and we decided to have a change in our life. So we moved to Qatar in 2014. So I've been here about 7 years plus. And one of the reasons that I moved and the attraction is that it was an academic institution, and the lifestyle for my family was more conducive to what we were about. So it was like the best of both worlds. I would be able to do more academic medicine, whether it's teaching residents, teaching medical students, fellows, that can also develop my skills, have opportunities for research, to have opportunity to do quality improvement, which I primarily focus on at Akhnuwkh General Hospital. So this is where I am right now. I'm one of the senior consultants in our department, general medicine. We are one of the biggest divisions in our hospital. We have more than 60 consultants. We have about 100 plus residents. We have about 10 fellows. So we have a big pool of physicians. So there's always opportunity for learning, teaching, and improvement of skills. The simple answer is something within the kidney is not functioning well. So the first thing that we look at is what is the baseline creatinine, and that's very important because for some reasons we might see an elevated creatinine, but as we know, creatinine is a byproduct of muscle breakdown. So for someone who is more have a bigger physique or very muscular, their serum creatinine at baseline might be high. But in any event, if we're able to identify that there is a rise, some quotes about 1.5 fold rise, and then we could say that there is a function. The reason why the creatinine is elevated is that the function of the kidney has been compromised, and we have to determine whether or not this is a reversible situation or a permanent situation. I think that there is something that we can develop. So for example, if we look at acute kidney injury or kidney injury, we can categorize it into 3 aspects. We could say pre-renal, there's something that's happening before it gets to the kidney. For example, low volume, or someone that's vomiting, having diarrhea, or dehydrated. And then we can look at post-renal. So for example, we know that if someone has like an enlarged prostate for males, or they have some kind of blockage in their bladder, then that can also cause acute kidney injury. And this is something that can be done maybe surgically. And then for the vast majority of conditions, there can be related to something within the kidney itself, any level of the kidney. I believe that if we do have a specific biomarker, maybe we may not be able to identify, we don't need it for the pre-renal or for the post-renal, but for the intrinsic renal disease, then we can kind of eliminate the need to do a host of tests. And also it can kind of give us an indication that, say, for example, this biomarker may suggest that this is a glomerular disease, and then we can focus our attention on that, and which is very important because there's a number of diseases that will fit in that category. And also, as we know, with a lot of conditions in medicine, timing is very important, especially with renal acute kidney injury. The longer that we have patients in that state, the most likely it will progress to chronic disease, which can lead to further problems. So As I mentioned, it depends. So the way I would categorize it, is it something, for example, if it's pre-renal, so we take the history, say, for example, a patient may say, I haven't eaten for several days, or they may have an acute illness, whether it's a viral infection, bacterial infection. Usually our first line management would to rehydrate. We use IV fluids. We can use isotonic saline, and we can observe. We can repeat the creatinine, and we can observe also the urine output to see that if that's actually the case. Now, when we have the extreme situation, say, for example, somebody is extremely ill and part of the sequelae of the disease, they go into renal failure, yes, hemodialysis is a viable option, because it basically buys the patient time to filter all the toxins, and then once their body heals, then they can start the recovery phase. And if you don't have that option with the dialysis, again, then we can get to the point where the renal function may not recover, and then dialysis will be like a long-term solution, and that comes with a lot of complications also. Now, again, if it's post-renal, then we look at whether or not there's an obstruction. They might need Foley catheter, et cetera, and then we can go from there. But I do agree that hemodialysis, usually when we look at like extreme cases, for example, someone has uremia, or they have mental status change, and they have abnormal electrolytes, for example, their potassium is extremely high, then we should do dialysis immediately. And we do have criteria for emergent dialysis. So a theme that I'm always going to mention is it depends on the history. So the most important thing is, based on the history and evaluation of the patient, what's the likelihood, what's the likely etiology of the kidney disease? Now, for example, if we say we assess a patient, and let's just say, for example, they're asymptomatic, there's nothing that we can think of that would contribute, and then you measure their serum creatinine, and it's significantly elevated, and you notice that from the previous interaction that it was normal, or a high normal. The first thing that I will look at, and the advice I will look at, is look at other parameters. Is the urea elevated? Is there an issue with the electrolyte? For example, do we have acidosis, low bicarb? Do we have potassium, whether it's high or low? Because that would give us an indication that there is something, a chronic manifestation that's developing, not just an acute phase. And also, we will also discuss the urine output. Have we noticed a change in urine color, urine frequency, et cetera? The first thing that I will tell them is we need to do urine analysis, because one of the things that we can rule out quickly is this some type of infection that's going on that can be easily managed and treated. Also, we can check the urine electrolytes to see if it's actually dehydration, or are they losing vital protein. So we check the protein, 24-hour urine protein. Once we have that information, as soon as there is an abnormality within those parameters, I wouldn't hesitate to refer to a nephrologist. The reason why is because there's further evaluation that needs to be done. Say, for example, if it's an elderly individual, we might need to evaluate them for multiple myeloma. Or if someone has diabetes, they might be developing chronic kidney disease. Or say, for example, we may check for autoantibodies because this might be a manifestation of lupus. I have sent several cases in my experience where the first manifestation of lupus was actually from acute kidney injury leading to chronic kidney disease. So I think for the general practitioner, once they do the basic evaluation and they rule out any reversible causes that can be easily managed, if there's something that is more extensive, then I would immediately refer to a nephrologist. And at the same time, you can do the basic investigation and refer to the nephrologist so that they can have information regarding the specific case. I definitely believe that there are conditions where acute kidney injury that may lead to chronic disease are related to specific environments. For example, we'll start with the simple case. In our area, we have temperatures that could be extremely hot. And a lot of people that we may see, they don't hydrate themselves effectively, or they might spend a lot of time in the heat. So definitely they can become hypovolemic and lead to acute kidney injury. So there's a lot of education from that standpoint that needs to be done. The other factor when we talk about one of the leading causes of renal diseases, when we talk about hypertension and diabetes, we're starting to see a cohort of patients from especially Southeast Asia. At a younger age, they are developing diabetes and they're developing hypertension, irrespective of obesity and even irrespective of diet. So there's some genetic component. And one of the challenges is that there is not a aggressive primary care presence or education to those patients. So they're not being monitored. They're more likely to seek medical attention once they become ill. And sometimes when they become ill, they're already at end stage where we see where their creatinine is significantly high and they have metabolic acidosis and hyperkalemia. And then that's when we talk about where they need the dialysis right away. And then going back to my experience in America, now when we talking about, obviously, there's a group of people, like for example, African Americans, we see a higher percentage of renal disease, acute kidney injury. I think part of it is when we look at some of the diseases, for example, high prevalence of diabetes and also hypertension. And from my experience, there is still not 100% trust in the medical field. So there's going to be a lack of awareness, lack of seeking medical attention for routine evaluation and preventative care. And then we also, when we go to the abnormal other findings like hepatitis C, we'll see a lot of cases from, like, for example, North Africa, where they have a high prevalence of hepatitis C, so manifesting liver disease and also renal disease. Also, some areas when we talk about certain types of infection can lead to renal disease. So I do believe that we have to do a closer look and kind of cohort certain groups of people, whether or not it's from their environment and also their ethnic background. And I think it contributes a lot to seeing some groups of people have a higher prevalence of acute kidney injury than others. I think in the early part of the pandemic, one of the things that I noticed, and we're talking about anything outside of COVID, a lot of people have suffered. What I mean by, as far as routine care, routine follow-up, routine procedures, like a patient may have chronic kidney disease, okay? And then, they're not, they might have telehealth, et cetera, but you can't do blood tests with telehealth. And a lot of times their symptoms, it may be vague, but they're not, they're being downplayed. So we will see a lot of people present with acute kidney injury. Also, if we include new onset diabetes, so it'll be a lot of new cases. Obviously, we know retrospectively, they most likely had it for time, but because they haven't been followed up, that's what happened. So, and then once we start getting into understanding more COVID, then a lot of the, say, for example, we could say some of the causes that we see of acute kidney injury may be COVID related. And sometimes it was challenging because there are so many other issues that's going on with the patient when they're ill that, the binding factor was the COVID, but there's we see hyponatremia, we see people, any viral illness, they can be ill. Now, so the challenge was, okay, is it specific to the virus, or is it just kind of like just being generally ill? Moving forward, as we become more accustomed to managing, I think we're doing a better job at kind of protecting ourselves from, as healthcare profession, from exposure, but at the same time reaching out to a lot of the patients that are at risk for kidney injury. Especially, as I mentioned, people who are working in extreme heat, people who have hypertension, people who are, some of their dietary habits are not up to par. So I think going in the future, because we have so much information about this virus and how it affects people, I think we can be better managed. You can be cautious, but at the same time, we have to continue how we were practicing before, um, in a way that we still have to identify these patients that are at risk for kidney injury. That's very interesting because somewhat related to what we're discussing is we will often have a lot of patients that get care or treatment not only in Qatar, but because it's a global international community, as you're probably familiar with, people travel to other countries and get medical care, whether or not it's surgical care, whether it's not as medication. Sometimes the medications are not familiar to us. They might be in a different language. The patients might not understand. So there's always a challenge. And then there's also supplements, vitamins, etc. So one of the things that I always, and I instruct my juniors, residents, and also medical students, is we have to be a little bit more creative of how we ask the question. For example, we can't necessarily say, okay, what medications do you take? Or what supplements do you take? What vitamins or minerals, etc. Usually what I tell them is say, okay, just tell me on an average day, what do you do? What do you take? What do you eat? What do you eat? What do you take besides food? So it's like you have to kind of just simplify it to say, okay, you woke up one morning, okay, you did X, Y, and Z. You brush your teeth, and then we go to what kind of toothpaste you use. Where do you get your vitamins? Where do you get your medicine from? So sometimes that's also important too. So not only what they purchase, but where, okay? Who gave it to you? What type of person you go see if you have an ailment, okay? Where do you go? Where do you get your treatment from? So we have to kind of be more broad, more comprehensive when we are approaching these patients. And also we try not to ask in a way to be judgmental. Because a lot of times they can kind of sense that if we feel as though they say, okay, if I'm asking this question because I believe, like they may say the physician believe that it's my fault that I'm sick. So we try to eliminate that type of interaction and just kind of just give general information. I just need to know everything you've taken because we need to see if this is something that can help you, something that you need to continue. And I always tell patients also, we kind of give them more education that we're not saying that this particular item is bad for you, but we're saying if you take this item in combination with another item, then it might cause problems. And they kind of like, oh, okay, I understand. So if we could have that approach, I think we'll be more successful in getting that information, because you're right. It's a lot of, especially, and I think it's even worse in America, because people can just go online and just buy anything. I'm pretty sure you heard some cases of people taking ivermectin for COVID, because it's a platform online and people, making testimonials and say, oh, I did this and it works. And then a lot of people, they just jumped on it and they just take it. And unfortunately, we're seeing a lot of negative impact. People are hospitalized. So I think, the education part from us, from the physician standpoint, is just we approach the patient non-judgmental, non-threatening, and more comprehensive as far as how we ask the question, and try not to use technical terms that they may not understand, but just kind of use general terms. I always say, just tell me everything you take besides food, and just tell me what it is. And also use graphic. Sometimes they might not know, but just say, okay, show me the picture, or show me the website where you got it from, or show me the clinic where you go to. And then we can do our own investigation. I think that's very helpful in my experience. That's a very good question. And I'm to my knowledge, I'm not sure if it's a direct link. Like say, for example, if someone is taking PPI, that they can have acute kidney injury. I would venture to guess that it probably depends on the individual, and it might be with a combination of another medication or a pre-existing condition. Now, obviously, we know NSAIDs is notorious to cause acute kidney injury, and then we might have antibiotics, et cetera. But I will. It's definitely possible, and I think that's something that we can look into. My personal opinion, I always every prescription, non-prescription medication, any foreign substance that you take is always a possibility to cause injury, not only to kidneys, but any type of organ. So it's not entirely say that it's not possible or not, but I'm just not sure as far as if there's a direct link. But that's something that I can definitely look into, and something that we should in the medical community look into, because you're right. If you go to an average pharmacy, like say, for example, in the United States, you will have a whole aisle just for gastric problems. I mean, you have all different formulations, type of medication, and it's just, you just pick it up and you take. Again, there's no regulation. Obviously, there are instructions and there are warnings, but the average person is not reading it. They say, "Oh, I'm going to take this. I'm going to take it." And then some people, if they don't feel better, the first thing they do is they take more. That's like a knee-jerk reaction, especially when it comes to pain or upset stomach or something that you can feel. When you don't get that immediate relief, you say, "Oh, maybe I need to take 2, maybe I need to take 3 times a day," and I definitely can lead to problems. So I will venture that that's possible, something that we need to definitely monitor closely. The first thing I will say is trust your training and trust your education. Now, obviously, as we move into the future, more information is always available, and sometimes there becomes abundance of information and it becomes confusing, but you always have to have a foundation. Say, for example, we know that if you have a systematic, stepwise approach to analyzing a condition, whether or not it's an acute illness, whether or not it's a chronic illness, whether or not this is something that is new, as far as new information, a new disease, like for example, COVID, where, this is a new phenomenon. If you have the basics, understanding the condition, understanding the symptoms, understanding the human body, how it works, how it protects itself, how the immune system works, how the digestive system works, the cardiac. These constants are always going to be the same. It's always going to be the same. Whether or not we have a new terminology, a new disease, if we stick with the fundamentals and the basics, and then you build upon. And one of the things that I always say is stick with resources that you are familiar with, and try not to venture into things that are not verifiable, because what happens is there's going to be a lot of conflicting information that's always going to be around. But if you stick with the well-known established resources and not focus on things that are obscure, then I think it will limit the confusion, and you can build upon it and become well-versed and more confident in understanding how to manage specific disease processes that are ever evolving and becoming new. The other thing that I always tell is that you always want to develop more skills. What I mean by that is don't rest on all of the clinical skills that you have. Say, for example, if you're in medicine, one of the things that is focused is point of care ultrasound. So develop that skills. Develop skills as far as doing invasive procedures. Develop skills as far as reading clinical imaging. Okay, because one of the things that I think was happening, and the difference between when I was training and when I was practicing early on, is that there's an overly dependence on other physicians to kind of verify your findings or verify the management. And what happens is that you'll kind of get, especially in internal medicine, you become more like a referral. You become a physician of referral. Say, for example, you have a patient with an infectious disease, so it's a knee-jerk reaction. Okay, let's get the infectious disease specialist involved. But in the meantime, the the progression of treatment, it kind of becomes stagnant. It's still, you can still get the specialists involved, but you have to have some kind of progression of, you about build a foundation. Okay, we did this, we did X, Y, and Z. We treated with this. Now we're at a standstill. Now we bring into the specialists to get help, instead of just going to them directly and say, this is what's going on, what to do. And I find that a lot of young physicians are getting into that habit and not thinking for themselves and using critical thinking to kind of understand what's going on. I think when you have continuous development of skills, then you become more confident, and then you can kind of manage independent of specialty input as far as information. Now, obviously, the skill part, you're not going to be able to do like brain surgery, etc. But at least you know that this needs to be done. The pre-op preparation can be done by us, and then everything then you hand over to whatever needs to be done. I think that it is definitely a matter of semantics. That's part of it. But I agree that if you look at it at baseline, everything can be boiled down to personalized medicine. But one of the factors that kind of like make it challenging is, say, for example, if you work in a big institution and a lot of things are become standardized. Now, I think there's benefit when you have standardization, but I think what happens is sometimes it can lead to complacency, and we can we're trying to fit everything into a specific diagnosis just so that we can say that this needs to be done, or whatever. And also we have another community when people are very a stickler with guidelines. Okay, guidelines. And what happens is you start to find yourself that you might have an 85-year-old with a blood pressure of 145 at 75. Then they say, oh, the guidelines say that we need to start antihypertensive. But then you start to think about, okay, this person is 85 years old. They don't have any cardiac issues. They're relatively healthy. Why are you going to introduce a medication that can potentially lead to harm? So we're not thinking from that standpoint. So again, I believe personalized medicine is very important, but the tools that we have, I think we have to put them in a proper perspective. They're frameworks. They're kind of like, okay, let's see what are the parameters that we need to work within. But it shouldn't be, you shouldn't have the position or the thought process that this is like a must. You must, order this test for every single individual that comes with chest pain, or you must have a CT scan for everyone who has a headache, or etc. And what happens is now it can improve healthcare overall, because then we're not going to be doing unnecessary tests, unnecessary hospitalization, unnecessary investigation. At the end of the day, our job is to do no harm. And this is one of the ways that harm can be done to patients. So we have to personalize, and I think if we do it that way, the patients themselves, they have more of a connection with us as physicians, because they know that we're listening to them and they're specific. We're not treating them as a disease or a diagnosis. We're treating them as a human being. That's a very good question. Probably I will be in some form a teacher, whether or not it's a professor at a university or a teacher in grade school or something like that. I think, I always feel like I have to have some kind of interaction with people and also, have an impact and development and building long-lasting relationship. So I know I wouldn't be able to do something where, I'm stuck in an office all day and just on a computer. I know I can't do anything like that. So I probably would do something in the education field if I wasn't a doctor.